Bismillahirrahmanirrahim. Assalamu alaikum, everyone. My name is Dr. Junaid. I'm one of the neurologists in Maruf. And today I decided to pick up this article that was published around 3 years ago in the New England Journal of Medicine. And the reason I wanted to pick this one up was because there's a big, debate, especially in the ER settings, or seeing stroke follow-up cases who are on dual antiplatelets, whether it should be a dual antiplatelet or a single antiplatelet. So there were several studies that were done in the past that actually looked more into it, and this was one of the study that was done. So I'll talk about this one. So the objective of the study was that in general, in routine stroke guidelines, there has no recommendation for dual antiplatelets. Only a single antiplatelet as an initial agent has been used. And especially looking at those population who presents with high risk, like transient ischemic attacks, or people who have like very minor stroke and are very low on the NIS stroke scale, they are not offered any TPA because they have non-disabling symptoms, and also they're not even candidates for like thrombectomies. So looking at these population and seeing if dual antiplatelets have a role in this group of patients was main objective of this trial. So when this trial was being conducted, another similar trial was being carried out in China by the name of John's trial, and that the results came back before the Point trial even published their results, and they showed that there was a 32% lower risk of stroke, but if treated within 24 hours. And I'm going to talk about the comparison between chance and trial later on, just to give you a perspective. And one of the drawbacks was it was just conducted within the Chinese patients, so there was some restricted ethnic population. So the Point trial was basically, it was a randomized, double-blind, placebo-controlled trial. It was a multi-center trial in various countries, but most of the patients, like 80 to 85% of the patients, were within North America. The enrollment was for 7 years, and they followed up each patient for 90 days. However, there were some premature discontinuations that I'm going to talk about. And the primary analysis was to look for intention to treat, and look for hazard ratios, whether either combination therapy is better or a single agent is better. So they did, in the paper, they discuss about the inclusion criteria, and the main basically points were at least 18 years of age or more, having low NIS stroke scale of 3 or less, and these are basically non-disabling symptoms. For example, if the patient comes in with aphasia, and so typically those are the candidates for thrombolysis, but low NIS stroke scale and the symptoms are non-disabling, so those are the candidates that are not considered for TPA, so including those. And people who have high-risk TIA, and the high risk is calculated based on the ABCD2 scale score, and I'm going to talk about that in a bit. So in doing a neuroimaging in the ER settings to rule out any intracranial hemorrhage, any tumor, abscesses, or anything that can explain those symptoms that they present with. So ruling those possibilities out, and ability to randomize these patients within 12 hours of onset. A quick word about ABCD2 score. We commonly do this in the ER, especially when we get a call at night in which the patient comes in with some transient symptom that improves. So we try to dig this information from the history to calculate whether the patient needs to be admitted or can they go home and come back next day to the clinic. So the age, you get one score for age 60 years or more, one score for if the blood pressure is more than 140 or 90, 140 by 90. And the clinical features are important. If they have unilateral weakness, that got improved, that's 2 points. If it isolated speech, that's 1 point. If there's combination of both, that's 3 points. But if apart from this, you don't get any point for dizziness, isolated, or vertigo, or numbness, or tingling. You don't get any point for that. Duration of symptoms, if it's more than 60 minutes, you get 2 points. Between 10 minutes and 59 is 1 point, and then you get no points for that. And they have diabetes, established diabetes, so that's 1 point. And this study that was published in Lancet in 2007, the estimated 2-day score, if the score is high, 6 and 7, the 2-day stroke risk is 8%. If it's moderate score, 4 to 5, it's 4%. And if it's low, it's 1%. So the study, the point trial included anyone who had the moderate or high risk of 4 or more was included in the trial. This is the NAS stroke scale. I'm not going to dig into this. It's just looking at different neurological symptoms and scoring them. It scores from 0 to 42. Higher the score, higher the deficits. Lower the score, lower the deficits. So it was looking for anyone who has score of 3 or less was included in the trial. Exclusion criteria, it has an exhaustive list. I'm just going to point out the main ones. So like I said, initial TIA, if it's limited to numbness or just maybe some isolated visual changes, or dizziness or vertigo, that was excluded from the trial. Anyone who has received TPA or any thrombolysis within 1 week was excluded. Any candidates who are candidate for TPA, like I just mentioned, if they have if they have isolated aphasia, they're a candidate for TPA with low NIH stroke scale, or if they have a thrombus and endovascular therapy is recommended, so they're excluded. Any patients who present with AFib or cardioembolic stroke or cardiovascular disease who require anticoagulation therapy, and they are already on a planned, dual antiplatelets, so they were excluded. Any history of GI bleed or major surgeries in the past 3 months, history of intracranial hemorrhage, or any contraindication to aspirin or clopidogrel was excluded, or anticipated use of any NSAIDs for more than 7 days during the trial period was also excluded. So basically, the trial treatment was basically, randomization 1-to-1 ratio. Either the patients will receive the clopidogrel plus aspirin versus placebo plus aspirin. So that's how they were randomized. So the group that was receiving clopidogrel, they were given a 600 milligram loading dose, and then followed by 75 milligrams from to the point, the 90-day mark was the end of the period, the treatment period. So they were given 75 milligrams every day. And the open label aspirin that was given was 50 to 325. So it varied in dosage, and that was based on the physician's preference in the ER setting. And the placebo that was within the aspirin group, it matched the appearance and the taste of clopidogrel tablets, just to make sure that it matches the both groups. And what they were basically looking for, the primary outcomes. So the primary efficacy outcome was the risk of composite ischemic stroke, myocardial infarctions, or death from any vascular causes or major ischemic events. So composite means combination of all of these. That was the primary efficacy outcome. And the primary safety outcome was risk of major hemorrhage, either it's brain hemorrhage, intraocular, or any hemorrhage that is requiring more than 2 PRBC transfusions, or deaths related to hemorrhage was the primary safety outcome. And the secondary outcomes was basically the breakdown of the primary outcome, doing secondary analysis of looking of risk of just separate of ischemic stroke, looking myocardial infarction, and looking for ischemic, other vascular ischemic causes or death related to other vascular ischemic causes. And the secondary safety outcome was again breaking down of the primary safety outcomes. Basically, that was how it was done. So the methods, so basically, like I said, the main model was intention to treat model. So initially, when they were doing the study, they anticipated that at least 50 patients would, if they are in the trial will have a power of at least 90% to look for the hazard ratio of 0.75. However, when they did the first interim analysis of the results that were coming out, and their intention was to do a secondary analysis of all these subgroups, they observed that the sample should be increased to at least 5,800 patients to have at least a trial power of 80%, so that they can do more sub-analysis in the group. However, the 5,800 number was never reached, and I'm going to talk about that why. Basic statistical methods were used with log rank tests to compare, random from the time of randomization to any first occurrence of the endpoint, either the primary or the secondary, either the primary safety outcome was reached or the primary efficacy outcome was reached. And the hazard ratios were calculated using the proportional hazard model to estimate the hazard ratios and 95% confidence interval. The treatment effect was monitored for 4 time periods, from days 0 to 7 versus 8 to 90, and also first month versus the first month to the end of the 90 time period. So these 2 time frames were actually looked for. So here were the results. Just a disclaimer that the trial was discontinued early on in December of 2017 when they only reached like 1,000 less of the patient that were actually targeted. So that was like 83% of the actual target. And the reason was the safety signal of major hemorrhage exceeded in the combination group. And the treatment effect also crossed the significant boundary. So they basically halted the trial at that point, and then they basically analyzed the data. So out of these 4,881 patients who were randomized, so pretty similar in both the placebo, the clopidogrel plus aspirin compared to placebo plus aspirin group, and then 29.6% had premature drug discontinuation as compared to 27.5% in just in the placebo and aspirin only group. And 93.6 patients completed the trial as compared to so pretty similar in both the arms, the combination group versus the single aspirin group. And pretty similar number of patients that were included in the primary analysis from both the groups. So here are the baseline characteristics of the patients in both the groups. And just the bottom line was there was no statistical difference in the baseline characteristics. And if you look at the patients that were included, so pretty similar in high risk TIA that I just discussed, the ABCD2 score is 5 between both the groups. And also the NIS stroke scale was pretty similar in both the groups as well. Otherwise, there was no statistical difference between combination versus single agent group. All right, I'm going to spend some time on the results. So looking at the first primary efficacy outcome, which was the composite of all the stroke or MI or death from ischemic vascular causes, as you can see that it was significant. It was lower in the combination group as compared to aspirin, and the results were statistically significant. So meaning that combination therapy was better as compared to single agent in composite. And also, I'm going to jump to primary safety first. So the major hemorrhage again was statistically significant. It was more 0.9% as compared to 0.4% in the single group. But when they did the post hoc analysis of the secondary efficacy outcomes, so the only significant was the stroke, that there was a significant reduction, and it was 4.6 as compared to 6.3 in dual versus single group, right? Otherwise, if you compare MI or death from other ischemic vascular causes, they were not statistically significant. The other thing that was noted, interestingly, was the ischemic or hemorrhagic strokes were more on the aspirin-only group as compared to the combination. And again, if you look at the composite and you include the hemorrhage as well, there were no statistically significant data. However, if you look at the coming back in the major hemorrhage group, any hemorrhage related intracranially, and if it's symptomatic or death related intracranial hemorrhages, there were no statistical significance in both the groups. However, what accounted for more patients was major hemorrhage other than intracranial hemorrhage. So that means that major hemorrhage involving the GI or other part of the body, or minor hemorrhages as well. So these were the main groups that basically was seen more on the dual antiplatelets. But if you compare the risk of hemorrhage in intracranial group, there was no statistical significance between the two groups. The other thing that they also looked at was, the risk of hemorrhage in the dual antiplatelets versus aspirin. So the risk of hemorrhage was greater after the first week and before the 90-day or the 3-month mark. but during the first 7 days, there were not major risk of hemorrhage that was noted. But if you look at the efficacy, if you look at the paper, they basically talk about that the treatment effect according to time period, the greatest benefit was in the first 7 days, and then in the first 30 days, and then in the 90 days. So as the time goes along, the first the first 1 month had greater benefit of dual antiplatelet as compared to from 1 month to the 3 month mark, where kind of it plateaus. And I'm going to show the diagram in a bit as well. So this was the efficacy outcome. So the first 7 days was the major change that you can see, that the event rate in patients who are on dual antiplatelet groups were right from the get-go, it was pretty low. And I mean, statistically low, I would say, as compared to the aspirin group. And in the first 30 days, that was the main area that was seen, that showed reduction in the dual antiplatelets. But after 30 to 90 days, there was no statistical significance between both groups in reducing the event rate. And that's where the term comes, you can use it for the first 3 to 4 weeks in patients who present with, high-risk TIAs or low ischemic strokes. And this was the primary safety outcome, which is the major hemorrhage. And if you look at this data, you can see that the dual antiplatelet group was 0.9% as compared to 0.4% at the 90-day mark. And the authors concluded that the risk of hemorrhage kind of remains the same throughout the 90-day period. Like there's no difference. The risk of hemorrhage by using dual antiplatelets is the same throughout the 90-day time course. So basically, this is the subgroup analysis of looking at various baseline characteristics and looking if there was any statistical difference between the two groups. So basically, this side is the combination group. This side is the aspirin group. And basically, the more it's on this side, on the left side of the curve, basically dual antiplatelet wins. If it's this side, it's aspirin wins. And if the confidence interval is crossing the 1.0 mark, it's statistically insignificant. And basically, there was no significant treatment by subgroup interactions in these pre-specified subgroups. But however, the authors do claim that, remember, the trial was discontinued early on because the primary safety signal was reached about the major hemorrhages. So they basically determined that the available data for analysis was limited by the power of the study as well. However, there was no difference in treatment effect according to daily aspirin dose used in the trial. So author basically, in the discussion part, they basically talk about 4 major things, right? The first is the minor stroke or the TIA patients who received dual antiplatelets. They had lower risk of major ischemic events, but a higher risk of major and minor hemorrhages. And again, highlighting that the major and minor hemorrhages are, they were non-intracranial. And if the minor hemorrhages were intracranial, they were not related to any death or disabilities. And ischemic stroke accounted for most of the composite events. So the secondary efficacy outcome that we discussed, so the reduction of ischemic stroke was most statistically significant, and it accounted for most of these events. However, reduction in cardiovascular, like MI or other vascular events, were not statistically significant. They did include that they could not make any direct comparison between the clinical and safety outcomes between these, between the primary efficacy and safety, because they could not ascertain that, if the patient had hemorrhage or from GI cause or other minor hemorrhages, did that affect their disability or not? So that was never included, so they could not make any direct comparison. However, they did estimate that for every 1,000 patients that were treated with dual antiplatelets for the first 3 months, it would prevent 15 ischemic events, but would cause 5 major hemorrhages. So again, coming back to the CHANCE trial that was done around the same time period as the POINT trial, The first point was that there was a big population difference. The chance was purely in the Chinese, and point was multi-center, but majority of the North Americans and some Europeans and from New Zealand. Again, Asian ancestry population, and mainly in Chinese, they have, this polymorphism in gene encoding the CYP2C, 19. We sometimes check that basically leads to incomplete metabolism of clopidogrel, and that could account for, the thing. But what the CHANCE trial did see was reduction in stroke, but no increase in risk of hemorrhage. As compared to point, they saw reduction in stroke, but there was a statistically significant increase in hemorrhage. And the reason could be of these, the two medications, they were combined for the first 21 days in the CHANCE trial, but in point trial, they were continued for 90 days. And also the CHANCE trial, they did the initial loading dose of 300 milligrams, as compared to the point trial, they did a 600 milligram, and followed by 75 milligram daily. And also the duration was dual antiplatelets of 30 days as compared to the 90 days. And the reason that the point trial chose the 90 days was from another trial, which is the SEMPRIS trial. So what they did in the SEMPRIS trial was they had a medical therapy group with intracranial stenting as compared to medical therapy alone. And in the medical therapy alone in SEMPRIS trial, they used dual antiplatelets for 90 days. And they saw that the medical therapy was superior to stenting with medical therapy. So that's the 90-day mark they used from the SEMPRIS trial to look in the point trial. So there were some limitations in the study, of course. Number one is these results could not be generalized to patients with moderate to severe stroke, cardioembolic, or the patients who are candidate for TPA or thrombectomy. So any patients who comes to the ER who have a high NIS stroke scale and they have a like atrial fibrillation and they're a candidate for either thrombolysis, thrombectomy, or anticoagulation. So we cannot use this dual antiplatelet efficacy in that group, and also these patients were excluded from the trial. And the second thing was that symptomatic carotid atherosclerosis. So there was a limited entry criteria for this group as well, because we know that if they have carotid disease, they do benefit from dual antiplatelets, especially if they get carotid stenting, they are on dual antiplatelets. And this group was excluded from the trial as well. So that was a limitation. Another one was, of course, the trial was discontinued permanently in 29% of the patients in the dual antiplatelet group. And the other point that they make was some patients who come with non-disabling TIA symptoms, especially who have low ABCD2 score, and the event rates were lower in that group, can suggest that maybe they never had a TIA. For example, we sometimes get a patient who presents with isolated numbness that lasted for this long and they are diabetic. We're not really sure if that was a true TIA or not. And in the study, they noticed that the events rates were lower in low ABCD2 score. So it could be that they never had a risk of any ischemic event in future because they never had a TIA to begin with. And aspirin dose was varied in the two treatment groups. Like I said, the aspirin dose was chosen based on physicians' preferences in the inclusion criteria. However, the study did notice that there was no treatment difference in the various aspirin doses from 50 to 325 milligrams in the aspirin-only group. And the information on the stroke etiology was not captured to begin with. The study also talks about other completed trials on dual antiplatelets. So they talk about the Socrates trial, in which they basically compared the tisagrelor, which is a P2Y12 inhibitor, and they compared that with aspirin, and in an international population, and they found no significant difference between aspirin and the tisagrelor. The other trial that was again done for triple antiplatelets in reducing dependency after acute stroke, and they compared aspirin, clopidogrel plus diapridamole with either just clopidogrel or aspirin plus paridamole. in the first 48 hours, and they actually saw that there was no benefit of triple antiplatelet. In fact, it increased the risk of hemorrhages. So there's an ongoing trial right now, which is the Thales trial, in which it's kind of similar to POINT trial, but a different agent. And they're looking at the combination of ticagrelor with aspirin versus aspirin alone in prevention of stroke and death in the same population, and see if that decreases the risk of hemorrhage in this group and shows efficacy. So these are some take-home points from this trial. I would recommend any patients who presents with TIA or stroke, we should be using ABCD2 scores in our ER settings and NIS stroke scale to determine if these patients would benefit from dual antiplatelets. So I've given a table of ABCD2 score in the trial, and anyone can Google it as well, and putting that in the patient's chart and see if they are candidate for dual antiplatelets or not to begin with. And if they have a high-risk TIA based on the score, and they have low NIS stroke scale, and even if they are within the time window and they're not a TPA candidate, they don't have major vessel occlusion or suspicion of a cardioembolism or AFib, so they should be considered for dual antiplatelet therapy as early as possible. So based on this study, they recommend 3 to 4 weeks of dual antiplatelets, followed by switching back to a single antiplatelet agent. And this is based on the risk of hemorrhage more than 4 weeks. However, like I mentioned, the data from the Sampras trial that showed that there was no significant safety issues if the dual antiplatelets were done for 3 months as compared to stenting with medical therapy alone. So this is kind of a gray zone still. Some people prefer to use for 21 days. Some people still prefer to use it for 3 months. So that was kind of the crux of the POINT and the Sampras trial. So I think I will kind of end over here, and I'll take any questions.
Assalamu alaikum, Junaid.
Walaikum assalam.
Junaid, assalamu alaikum, Dr. Kadi. Can you hear me?
Yeah. Yes, I can. Yeah.
Thank you so much for a wonderfully done journal club. I just have a few questions for you, being a neurologist, and others who come from a cardiology background, and for others who are still looking at these patients along with other specialty interests. So here you have somebody in the inclusion criteria in terms of the external validity. This is for low NIH-SS score less than 3, and exclusion of the moderate to high risk ones, and where they are using a dose of clopidogrel, which normally for a low NIH-SS score is usually recommended, I guess, in most studies at 300 milligrams. So here they are using a higher dose of 600 milligrams. We know that it has a little more effects on ADP and other inhibitory aspects, but in terms of the usual, whenever you are looking at randomized controlled trials, it is always nice that people compare the comparator using the usual doses rather than using the unusual doses. So here the clopidogrel and aspirin limb had a higher than usual dose of clopidogrel that most of the neurologists and cardiologists perhaps would use for a low NIHS score to begin with. That's one concern, because obviously the efficacy is likely to improve, and no doubt when they went on to 3 months, they had more hemorrhage. The other thing is that in terms of the number needed to treat and number needed to harm, the number needed to treat comes out to around 65 here, and number needed to harm is 200. Yes, the number needed to harm 200 for an event like a major bleed and all that. I mean, the higher it is, that's great, that's good. Yet even the Data Safety Monitoring Board were concerned about those kind of events that made them stop it, because that's where the safety boundaries were. The third thing was the issue of the number needed to treat. So the number needed to treat in this particular group would be 65 to prevent one ischemic stroke or one of those composite outcomes that they mentioned. And in fact, in subgroup analysis, it was only the ischemic stroke which was improved. The others did not benefit. But then would you, as a neurologist, looking at this study, looking at its applicability, feel comfortable giving the 600 milligrams of clopidogrel, or you would stick to even for 4 weeks and then going on to single agent after the first 4 weeks? Or would you go on, would you use 600 or use 300 clopidogrel now in light of this study? Because obviously the number needed to benefit is also pretty high. It's about 65. And yet, most people are scared of stroke, but I think a lot of people are also concerned about the major bleeding effects. So I just want your comments on that. I know the study was well done. It has some good aspects to it. It's the intention to treat analysis and all those things, and the adjustment of power was done with the for the multiple comparison adjustments were done. That's fine. I'm just thinking that when you use a higher dose than expected, then obviously you're going to have perhaps a little better efficacy and perhaps a little better, a little worse outcomes in terms of harm. So that was expected, I think, in this study. But would you change your practice based on this?
So no, I still I'm more comfortable in using 300 milligrams as compared to 600 milligrams. When these type of patients come into the ER. And again, just based on the risks that you mentioned, especially like old patients and risk of, even if it's non-intracranial hemorrhage, even risk of other, GI related hemorrhages or any, especially a lot of these patients are in an older population range. So they're already at increased risk, fall risk and all the other things. So I'm still comfortable in using like 300 milligrams. That's what the CHANCE trial used. But I think that I'm not sure where the 600 milligrams came from in the point. I have to look in the Sampras trial if that's where they took the 90-day mark. And I'm not sure if they used 600 over there or 300. I have to look into that, but I would keep it to 300.
Thank you.
Anyone else with any questions before we break off? All right. Thank you so much. Thanks a lot for listening.
Wonderful presentation. Thank you so much.
Thanks.